Hello, everyone. Thank you so much for joining ELSO's special session webinar on COVID-19. My name is Elizabeth Moore. I'm joining you from the University of Iowa in Iowa City, Iowa. We have a few more people, just looks like, that are joining us now on Zoom. I will mention a little bit later, but we're also live simulcasting on our YouTube channel, so you are also free to watch live on there as well. So to get things going, I just wanted to remind everyone, on December 31st, 2019, the World Health Organization in China was informing of cases of pneumonia of unknown etiology. This was detected in Wuhan City. From December 31st, 2019 through January 3rd, a total of 44 cases with patients of this pneumonia of unknown etiology was reported to the national authorities. During this reported period, this agent was not yet identified. Today, about 113 days later, this virus has a name that we've all come to speak probably more times than we want to on a daily basis, which is COVID-19. The world has been turned upside down with over 2.5 million confirmed cases, resulting in over 180,000 deaths. As we've all been settling into our new normal, these dark hours have produced some of the most beautiful moments of unity. Rarely before in our history has the world been so connected in fighting a common enemy. Today, we've assembled an esteemed lineup of clinicians who are ready to share the lessons they have learned during this global pandemic. So a few housekeeping items to remind you of. So as I mentioned, that it's being live streamed on the YouTube channel, so you can go ahead and watch on that as well. At the conclusion of today's webinar, a recording of this broadcast will be available to view on demand on our YouTube channel. As well, we'll be ending with a Q&A session, and I'm excited to see that there are already some questions starting to come in, so it looks like we have an eager group here. We'll do our best to field all those questions and try to get them out to this panel. So please, if you can, try to direct your questions to the Q&A session. Those are where we'll be pulling the majority of the questions from. So to get things started, because I know that we have a lot of ground to cover today and stories to share with you, I'd like to kick off with our first speaker, Dr. Christian Bermudez, who's a professor of surgery at the hospital at University of Pennsylvania. He's the director of thoracic transplant and surgical director of the lung transplantation and ECMO programs there. So he's going to get us kicked off today and share with you all kind of what his experience and perspective has been during this time.
Can you hear me there?
Yes.
Perfect, fantastic. Well, first of all, welcome to all, and I want to thank ELSO for putting this webinar together. This has been a difficult time for all of us, and as Liz mentioned, it's been a perfect time to work together with, among all the specialties, critical care, anesthesia, and nursing, stuff like that. This has been a very unique moment for me and for all my team, as I'm sure for all of you. I'm going to be talking today, I'm a surgeon, and I'll be concentrating my talk on ECMO center organization and regional coordination. I have a co-speaker, Dr. Holt Murray, that is going to be diving a little bit deeper in regard to the regional coordination, because we have learned a lot from him. To be honest, we were not, before this pandemic, talking about this, especially in the ECMO field, but we have learned a lot recently, and I think he's going to share with us his experience. As a brief introduction, you all know this has been an unprecedented pandemic attributed to the SARS coronavirus 2. The World Health Organization declared pandemic in March 11, 2020. This is a highly contagious disease, frequently, especially ill patients involved in multi-organs, more frequently the lungs, but also other organs can be involved, including kidneys, liver, heart, and central nervous system. The ICU admission rate is high, and the need of mechanical ventilation also is high. With intra-hospital mortality, we have seen in our center and published between 10 and 20%, even can be higher. There is a potential of a massive surge of anterior proportion depending on the region. And to what we know at this point, the first case was reported in China in November 17, 2019. And we just learned today that the first case of a patient that died was here in February 6, 2020. Interestingly, despite of this happening already in November, we had very, very little information, mostly through social media, the newspapers. We all were expecting to have something similar to what we had with other pandemics in the past, including the H1N1 pandemic, in which our healthcare system will be able to manage with the usual interventions to be able to keep the health system at capacity. But the reality, we were not expecting this out of proportion, out of the ordinary wave that really took us by surprise, and things that were never seen before, and making a lot of decisions with very little guidance and less data.
Dr. Bermudez, can we make sure you have your screen shared for your presentations? It's not showing up right now.
Oh, thank you for interrupting me. That's a problem.
Sorry about that.
That's, excuse me. Thank you for interrupting me there. Is that better?
Excellent. Thank you so much.
Well, you have the introduction, and again, I was talking about the unprecedented effect of this pandemic that really took us by surprise. We thought our healthcare system would be able to manage the pandemic. We thought it would be similar to H1N1, but the reality, this is something that we have never seen, at least during our professional career. The moment the World Health Organization declared this a pandemic, the hospitals started to organize themselves with the incident command structures, using team of teams, in order to organize organizational frameworks and improve the communication among the system, developing also teams. There were different groups that were formed, including critical care, med-surg, operations in the OR, etc. But interestingly to me, ECMO came very late on this picture. We were not invited to these early meetings. And probably the reason for that is that we were getting some information from China that ECMO was really not something that would happen in this pandemic. These were very sick patients with a lot of inflammatory changes. Even though there was ARDS, ECMO was rarely needed. There were the first case reporting by Yang and his group with 6 cases, 5 of them died. We were also hearing from Europe that this was not really needed or rarely needed, and there were only 65 cases reported in ELSO in March 2020. And they were telling us that we should concentrate on mechanical ventilation and intubating the patients and not on ECMO. Interestingly, also data from Washington State here in Seattle showed no use on ECMO in the first series of patients. So the reality, we were getting mixed message that ECMO may not be something that we would consider in this pandemic. Shortly after, we started to realize that there were some patients that required this type of support. We were getting young patients that were supported, and people became a little more open to this concept. And a group of specialists started to talk about ECMO in patients that were not able to be managed with advanced therapies and mechanical ventilation, but always very careful mentioning that this should be done only in very selected patient population. The World Health Organization also suggested that ECMO could be a therapy to be used in this situation where other therapies have failed, and patients could eventually be referred to specialty centers. And other critical care societies also started to support this concept. Again, very careful at the beginning, mentioning this was only to be done in very selected patients due to the resource-intensive nature of ECMO. Unfortunately, when that happened, what I call the ECMO amigos, including Alain Combs and Dan Brody and other people, put this nice paper together telling us how to organize the response. We were ill prepared for this type of event, so we didn't know exactly what to do. We imagined, we start doing few things, but this paper helped us at the beginning to start to understand how to put things together, organizing personnel, equipment, facilities, and organizing our system. What we did in our hospital at Penn is, first of all, we modified the ECMO team deployment. Usually we base this on fellows as first responder, but this became an attending business to decrease the risk for our fellows. We kept the same care model with a trained nurse and a specialist. We created a specialty COVID consult team, mostly by the medical and surgical directors that would be on call 24 hours as an arbitrator. We changed the ECMO alert system, in which we were not responding now to ECPR, as we had difficulties at the beginning, try to identify if patients were COVID or not, and we were concerned about spreading this among the team. We started a process of education in the unit, especially the COVID unit and the ED, and how we would be providing the response. We re-educated the team, especially how to use the protective equipment, and we started the conversations about how we would be doing ECMO transport. This is a video that actually was shared on the ELSO, a social media platform, a very, very rudimentary video on how we use the protective equipment. Regarding space, we soon after approached the hospital. We tried to keep all the COVID units around the cardiothoracic ICU where we had all the nurses trained. We knew that we needed to be flexible, so we also offered to go to other units, but we tried to stay around to be able to provide a consistency of care. And we train our group in the placement of ECMO in negative airflow rooms or units. We secure immediately equipment. We identify our capacity. We secure pumps, oxygenator, cannulas, and other disposables, and also some protective equipment early on. Our response was based on a system capacity. We wanted to stay on a conventional capacity. We understood that if we got to a crisis mode, we would not be able to perform ECMO, but we discussed this with the administration, and we created some early rules to be able to provide this without restrictions. I know other places and institutions have had restrictions on ECMO, but we work in a very organized plan with our administration at the beginning to secure them that we would not be moving higher than early contingency capacity. But we soon understood, as we were seeing the map of COVID in the US, that this would be, the surge would be very diverse and would happen at different stages in different parts of the US. We also recognize that they would be distributed differently even within the state. And for that reason, we understood that we needed to start coordinators. We did coordinating the response with other centers in the region. We didn't want to have patients shopping around for ECMO or centers offering ECMO with lower restriction for certain patients. For that reason, we created rapidly a network of ECMO centers in the Pennsylvania region. Dr. Murray is going to expand in detail because in reality, I made this suggestion. I thought it was an extraordinary idea following what other centers have done in Europe and Asia. With this, the idea was again to try to concentrate, have uniform regional criteria, avoid patients being again transferred from multiple hospitals. And again, the way we did this was a weekly teleconference, identifying regional and center coordinators, defining the status of ECMO in our region, identifying indications and contraindications based specifically on our patient population in Pennsylvania, that as we're going to mention may be different to Japan and other regions. We came up with a regional ECMO criteria statement, and this is the way our working document looks like. As you see there, we can see the capacity of the different hospitals in the region. This really was very helpful because it allowed us to communicate on a weekly basis with the other centers, allowed us to dissipate all concerns regarding what was the other center doing in the city or in the region, and made us feel really much better prepared. So I really encourage other centers to do this, and I know other places in the country are also doing this. Allow us to identify, for example, the capacity. We didn't know in Pennsylvania was 124 ECMO systems, that we were able to perform around 100 ECMO support in the region without a major concerns. Also forced us to have a better understanding of what we're doing. This is our experience. We kept track more closely of what we were doing on a daily basis. We have patient support, about 0.8% of the admission to the University of Pennsylvania health system, half of them female. 3 of these patients have been weaned. The average support has been about 6.6 days. 2 of them died, surprisingly, of intracranial hemorrhage after we changed the protocol of heparin based on the reports of thrombosis. So we changed that protocol, came back to a lower PTG range. We had 7 of the 8 cases that we performed were lung rescues. Interesting, if you see on the left side of the screen, these patients were relatively young, between 30s and 50s. the weight was relatively high. I would say in the vast majority of them, we had even a BMI of 52 that actually has been weaned. All the cases were VV ECMO, and about 25% of these cases were in long-term support for more than 2 weeks. We defined the indications based on this consortium after prolonged discussions, and we concentrated mostly on VV ECMO. And we use what ELSO has an ERDS net as proposed. The only change has been in this pandemic that we have the use of chronic vials at least for 6 to 12 hours, and it makes sure that most of the patients, if not all of them, had non-muscular blockage. Again, we changed a little bit the concept of the CPR in this setting. We decided based on the reports that we were getting in our clinical experience with high rates of thrombosis that would concentrate on standard cannulation technique, that we would not use dual lumen catheter due to the concerns of flow and the potential of thrombosis. So we use standard cannulation in FEM or right IJ, right femoral vein. There were some considerations that were early appreciated when we had the discussions with this group. One of them, the different nature of these ARDS compared to previous pandemics that we have seen, better compliance, especially in the early phases of these patients. And we had a lot of discussions to consider early versus delay implantation, and we decided at the beginning to consider a later implantation after all the other strategies have been tried. This is slowly changing, but here across the US and in Europe, and that would be a good point of discussion later. We also, as we were discussing, a review and consider all the risk factors that are specific for COVID-19. You see this paper in which report the odd ratios for mortality in COVID-19 versus common acquired pneumonias, age, cardiovascular disease, diabetes, hypertension, lymphopenia, and chronic lung disease, and also the higher rate of other organ involvement, including renal failure, present up to 29% of the patients. That also made us consider doing this even in patients with dialysis. You've all heard about the high rate of thromboembolic complications. Between 20 and 30% of these patients have thromboembolic complications that could be seen in the lung. In pathology, these two ultrasounds are from our patients with RV clots, and this is a patient that we have on ECMO also with a right IJ clot where he had a dialysis catheter. So there is no doubt that these patients, we see more thromboembolic complications than previous cases of viral infections. That led to come out with the contraindications in which we were a little more liberal than others with the weight and renal dysfunction and stated recurrent immunosuppression. Even though we consider recent bone marrow transplant and immunosuppression and contraindication is liberal, this is a stated an area which we do a lot of transplants. So based on the data with the use of calcineurin inhibitors with some protective effect, it decreased the replication of the virus and eventually decreasing inflammation of these patients, we were still willing to consider some post-transplant for ECMO support. So we did things a little bit different to what other guidelines have proposed. Again, keeping ECPR only in extremely selected group in highly specialized centers with patients with ROSC. Regarding the ECMO, we know that in this population, about 20% of the patients present cardiac complications. About 5% of these patients will require a VA ECMO support that we kept as ELSO has also done the same indications and contraindications with the exception of ECPR. The other important point is that this group worked based on the recommendation from Holt and his group in Pittsburgh on the dynamic assessment tool. Where we wanted to make sure that if things got a little more complicated with increased capacity, we were able to provide ECMO in a fair, transparent basis. And we defined that at that point, it would be a very close selection with medical directors and a member of another team, part of the collaborative group. Fortunately, we have done that. The numbers of ECMO has continued to increase. More than 1,000 cases have been supported. The mortality seems to be, based on the reports from Europe, about 50%. That again is too early to tell. A lot of these patients are still on support. And to finalize, I want to say that ECMO preparedness, from my perspective, plays a key role in a successful and seamless response. And the regional coordination seems the logical action to take, especially in the uncertainty. And with that, I want to finish. Thank you.
Thank you so much, Dr. Bermudez, and we'll transition over to our next speaker, which is Dr. Holt Murray. He's Assistant Professor of Critical Care Medicine at UPMC and is a co-director of the Cardiothoracic ICU, as well as the Chief of Critical Care Services at UPMC Mercy. I also, as Dr. Murray, as you're switching over to share your screens, I just want to, I know there's a lot of people out there that are trying to change views and to make sure that they can see the slides. If you're changing and watching on a computer right now, you're able to change the views at what you see as primary. It sounds like a number of you might be on some iPads. So I just wanted to rest assured that we'll be making all these slides available after the talk, as well as the broadcast will be available to you all at the conclusion of the webinar. So if you weren't able to see the slides as you're viewing right now, those will be available to you shortly. And with that, I'll transition over to you, Dr. Murray.
All right, good afternoon. So as Christian alluded to, I'm going to go over how we got to the regional coordination that we did in Pennsylvania. And really it's compressing 10 years of lessons learned in hopefully just under 10 minutes here for everybody. Maybe if I can get the slide to change. So my first career was as a fireman, and going back to FEMA, there's some fundamental principles of emergency management. And in large part, we haven't been forced to address those issues when it comes to critical care or specifically ECMO. But those principles are fairly straightforward. They need to be comprehensive. Our responses need to be progressive to the threat at hand. They need to be risk-driven, meaning we need to assess the risk that's in front of us and develop a plan subsequent to that. And then a slew of issues with integration of other services, a collaborative nature that's professional, and then flexible to adapt to whatever concerns or curveballs that are thrown to us. And this is really where the story starts. Even though we're talking about something that's been put together over the course of the last month, the story starts for those of us that were doing this in 2009 with H1N1. And the number of ECMO centers and the number of ECMO runs at that time were relatively low, so that when we had cases of H1N1, they ended up being very centralized in nature. And there were quite a few lessons that we at UPMC learned from this. One was that we have a very hub and spoke system model with hospitals that are shared between another large referral center. And patients were referred quite often late to ECMO, just as it wasn't considered a standardized rescue therapy by the community at that time. And that's certainly changed over the last decade. We needed early identification and referral of these patients, and we also needed to really understand what our true capacity of ECMO patients was and how this affected our daily operations. And in this process, we developed adaptive staffing models as we got progressively more stressed with the number of H1N1 patients that we were supporting. So the way that we solve this as a system at UPMC, we have 40 hospitals that we interact with that send to UPMC Presbyterian. And a lot of this was done by our ICU service center with generation of some standardized mechanical ventilation guidelines for ARDS. And the key point with that is this branch point for people that are declining on conventional mechanical ventilation, to identify them early at the point of either prone ventilation or considering rescue therapies, such that we can evaluate them for ECMO support and candidacy. And then the other critical components of this that were lessons learned during H1N1 were just what are our requirements as far as physician, nursing, staffing, perfusion, and then devices and disposables, as well as our hospital capacity and ICU capacity. With the advent of COVID, because there was anticipated a great increase in the number of patients that would be reaching the branch point of ECMO evaluation, and as well as to manage system flow of patients, an ICU service center command center was put in place that provides a multitude of roles across the system. Some of it is screening of patients for transfer and evaluation to quaternary centers. Some of it is telemedicine component to our smaller hospitals. Within this, we added a layer of evaluation for inclusion and exclusion criteria at the very highest level. And then if they met the very highest level of inclusion or exclusion criteria for ECMO, referral onto the ECMO team for further evaluation. Our perfusionists have been exceptional at getting us a good handle on what our true resources are. And those resources include not only the devices themselves, which we can pull devices out of training areas that are still functional, but also, and probably more importantly, where we stand as far as disposable supplies and kind of what our burn rate of disposable supplies are, given the inherent limitations right now with replacement parts. And then from a system standpoint, we decided that as our system resources were going to be stressed, that we would offer ECMO to categories of patients that were progressively more likely to benefit from the therapy. And certainly the ELSO-derived REST score is our best piece of data in this regard. And putting them in these risk classes of 1 through 5 served as the framework for what we took as our dynamic assessment tool that you'll see later. But there's some real challenges with respect to disaster response in ECMO planning. The resource utilization is very high. The lag time between onset of ECMO and when they come off pump and get out of the ICU is long. And it's difficult to tell who really benefits from therapy early in their course, kind of compounding some of the decision-making that needs to occur. And the result of that is that the decision-making that you make today affects what your ICU capacity and your ECMO population will be 7 to 14 days from now. And so when we talked about dynamic criteria, we talked in regards to our residual capacity left. And if we left the capacity under 50%, we used our standard operating procedure, standard selection criteria, standard exclusion criteria. And when I say 50% capacity, this is maximum capacity. 50% capacity for us is around 10 to 11 people on ECMO, which reflects a very comfortable ECMO load for us under non-pandemic conditions. When we get to greater than 80% capacity, we're talking about 20 to 22 people on ECMO at our facility, which would be a major limitation with regards to our staffing model and our disposable supplies. Interestingly, we can probably put together another 10 to 15 pumps, but we consider that well beyond what we can do just from a nursing and ICU staffing standpoint. So our dynamic criteria was meant to be somewhat predictive in what we were going to face 2 weeks from now. It was meant to scale up as capacity became constrained, that our selection would become more stringent so that we would never leave the most viable and salvageable people without ECMO. But then it was also designed such that if peak and crest comes by us, that as capacity becomes available, that we loosen our criteria such that as the wave passes, you end up back in standard selection and back to business as usual. So within Pennsylvania, it's a big state. It's 13 million people. It's the 5th largest state in the United States. And over this area, UPMC has 40 hospitals. That accounts for 8,000 inpatient beds, about 760 ICU beds, and 3 ECMO programs. some of which are centered in the center of the state. So our first goal was to get all of our system hospitals kind of marching to the same tune, the same selection criteria. And what became clear after we did that was that we really have shared goals, all the ECMO programs in our region of Western Pennsylvania. We all want to save the most lives. We want to ensure that there's capacity for those most likely to benefit. We also wanted to provide some support and solidarity for difficult decision-making. As Christian alluded, we didn't want people to feel like they needed to shop around at the non-affiliated hospitals for an ECMO program that would take their patient. And provide some sort of simplicity and clarity for the hospitals to be able to call with confidence one of the ECMO programs that's in Western Pennsylvania and get similar answers. And the real benefit of that is that you develop fairness, there's transparency in the selection process. We maximize the benefit for our community, and we coordinate resources amongst facilities. And there is some regionalization that happens already in the state of Pennsylvania with the healthcare coalitions. But for Western Pennsylvania, the three major providers of ECMO within the Allegheny County region, which represents the Pittsburgh area, we all got together and agreed on the selection criteria. Mike Collins was great from Allegheny General in getting this together. And we sent out a statement via the health department and through the regional CMO leadership team that was formed for COVID to basically give the hospitals in the region the assurance that all the major ECMO centers in the area are going to be doing selection on the same scale, that we would coordinate our capacity such that one person was not overrun, and that we would ensure that there was smooth transition of patients from our spoke hospitals to the hub hospitals without any one area being overrun. And there's some basis for this. Doug White from University of Pittsburgh has been instrumental. The state of Pennsylvania has adopted allocation of scarce critical resources during a public health emergency document, and it basically provides some sort of structure for when we're over capacity with either ICU beds or ventilators. ECMO is not mentioned in this, and in this selection criteria, it talks a bunch about using SOFA scoring for fair and ethical determination of how these resources are allocated. And that's an interesting challenge for ECMO. There's some specific things that become ethical challenges, and that largely relates to selection criteria. Age was specifically excluded at the state level, and that document that Dr. White's been so good about putting forward with the UCLA team has been adopted in about 18 or 20 states at this point. But there's a fundamental difference with ECMO versus when you're looking at ICU admission criteria and allocation. And that's that age has been such a significant predictor of outcome. It's really inherent to selection criteria in ECMO. And in that way, the ethical teams really believe that this reflects more the way that we do transplant selection. And it's a little different than what you would do overall. There are concerns with stopping rules as you become over capacity. And obviously with the resource utilization that ECMO requires, it's going to take second place to ventilator and ICU bed shortages. If you're selecting people not to go to the ICU in general, in the worst of a crisis, it would be hard to advocate for ECMO in those same patients. So this is the timeline in which Pennsylvania kind of moved forward. By March 15th, there was a clear issue in Europe. The system's clearly stressed and probably beyond capacity, making decision-making on ICU beds paramount and ECMO secondary. At this point, UPMC reviewed its internal criteria And we had a system-wide response plan with the help of Mike Lazar at UPMC Susquehanna for how we were going to manage our system. Now, this rapidly went to become a Western Pennsylvania collaborative process with the Allegheny Health Network and Mike Collins and Danny Chu at the VA hospital. And then Dr. Bermudez and I had our first discussions around the 30th of March about what we would do as far as coordinating between the east and west side of the state. Shortly after Dr. Bermudez and I had our conversation, our health department announced the Western Pennsylvania's coordinated plan, and we began statewide discussions. And those have culminated in a consensus agreement across the state of Pennsylvania and how we're going to manage excess pressure and ICU beds and ECMO as it relates to that. And shortly after our consensus agreement, the ELSO phases of response, tiered response had come out, which fits nicely into the plan that we had for the state of Pennsylvania already. So over the course of about 4 weeks, we moved from solidifying local quaternary hospital ECMO selection and criteria to a very collaborative and informative statewide response plan. And so I guess I would encourage everybody to look around their region to the other systems that they interact with to make sure that the care and response is synchronized in some fashion, that the question of if somebody should be supported on ECMO is coordinated within systems and within hospitals, and that there's an ability to take the highly salvageable patients from a stressed area and get them the support that they need in neighboring areas. I think that'll do it from me, and happy to answer questions as they come forward.
Wonderful. Thank you so much. Much to be congratulated with. That's quite an impressive feat. Most days it feels like getting stuff coordinated just within the hospital is a challenge. So kudos to the teams for being able to really be able to look at this from a statewide and region approach. I am quite positive you'll continue to get questions on how you were able to successfully bring that to light. And with that, yes, you will have some questions at the end that I've seen coming in. So for those of you who had questions for Dr. Murray and Dr. Bermudez, we'll get to those at the end of the presentations today. So I'll have up next Dr. Osborn. I'll have him convert over and start sharing his screen here as I'm introducing Dr. Erik Osborn, who is the medical director of the adult ECMO program at Inova Health System in Northern Virginia, of which he's also a retired Army colonel. And for those who have caught, I know that he's made some national news with some of his, with one of his ECMO patients that was able to make it home. So hopefully he'll be able to share some of his success stories and what they've been able to do there in Virginia. So with that, Dr. Osborn, take it away.
Hi, Elizabeth, can you hear me?
Yep, yep, you're perfect.
All right, there's a little bit of a lag time. Thank you for inviting me. Excellent talk, Christian and Holt. Yeah, we were discussing some of those very issues this morning. So I'm going to talk about our experiences and some of the procedures that we've been doing. This is preliminary findings. We're still early on. So far, we've done 15 COVID ECMO patients. 7 currently are on support. We have 7 that are decannulated. 1 expired during cannulation. 5 have been extubated. 3 are out of the ICU with intact neurologic function, and 2 are at home. One of the things, we've had some early success, and I'm going to sort of talk about what we're doing and what we think, this is speculative at this point, but what we think might be giving us some good outcomes. I think the pre-ECMO management, we have an excellent critical care service here, and they're very strict about their ARCH protocol. So by the time the patients go on ECMO, they have not had their lungs beat up by high pressures and high volumes. We have rapid placement on ECMO if they're failing protection, paralysis, and proning. Most of our patients are diuresed pretty well when they get to us. Many of them are also on, if their D-dimer is elevated, they're already on low-dose heparin infusions. Our criteria, as we've discussed, we started off sort of anticipating limited resources. So we had our criteria much stricter than normally. That was sort of a younger age, previously healthy, no severe chronic end organ failure. Our oldest COVID ECMO patient is 56. They need to fail lung protective ventilation. They have a perfusion compromised by acidosis, fail paralysis, and fail proning. Our thought was that they sort of had to really earn their ECMO by failing at least protection, proning, and paralysis, and a PDF ratio closer, less than 100, or progressively declining over successive proning days, 3 or 4 proning trials. Pretty similar to the ELSO criteria. Our characteristics, age is 16 to 56. These are the men, the ages, they're all in their 40s and 50s, which is humbling because many of us are the same age. The female, we have 4 females and then 11 males. Most of them have diabetes, hypertension, and obesity. 73% have a BMI over 30, and we saw the article saying that the BMI is the single most, the pro-inflammatory state of obesity predisposes them to getting extra sick with COVID. 86% of our people are Hispanic, and that's true of the ECMO population and our population of mechanically ventilated patients. 80% of them had diabetes. Our cannulation, we have cardiac surgery and anesthesia. ECMO MD is done in the ICU room. We do FEM, we do with a 25 French IVC multi-stage, and then a return 19 to 21 placed using TEE into the right atrium, kind of what Christian was talking about. So we started off doing our normal heparin bolus, which is low, 50 units per kilogram. Once we saw the severe clotting, the thrombotic microangiopathy that these COVID patients had, we've gone up to 100 units or even greater after our first set of cases. We all use our PPE, PAPRs, and N95s. We've all been fit tested. Going from cannulation into procedures, we've done 9 bronchoscopies. So I've been living with these patients for about a month, and I've done a bunch of bronchoscopies, intubations. I wear my mask, and I haven't gotten sick. And we've been fortunate our team has not gotten sick. What we do for bronchoscopy is we get the room ready so that we can be out of it for about an hour. One person goes in, does the bronch. We make sure our medicines are topped off, the CRT, fluids are okay. We give them a nice neuromuscular blockade followed by an infusion. We place an adapter using a clamp, allowing the bronch. A single provider performs the procedure. RT is outside if necessary, but they kind of coach us on how to use the vent. And then after bronchoscopy, the provider that performed it is the one who goes in, and under the direction of the nurses, we get to play with their pumps, which they love. And it's just to limit exposure. Tracheostomy. So we've done a total of 6. And similar to bronchoscopy, we prepare the rooms, so limit the amount of people that are in there. We just did one before I came here, myself and Dr. Ryan from cardiac surgery, and then he had one of his OR assistants with him. So there was just 3 of us in the room. Get the room so it can be prepared, no intervention for an hour, paralyze them. We got the vent ready to put it on standby as we were placing the trach in. And then we do a perc trach with a partial open electrocautery. And we do it through bivalve or heparin. The amount of clotting in these, I know that Troy's going to talk about it later, but it's been very impressive. Good thing is we don't have bleeding, but I'm a little bit more scared of clotting actually. So we keep our heparin and bivalve running. And if we have post-procedure oozing, prolonged direct pressure has been effective. Ventilator management, once they're on, ECMO has been the same as our other ECMO patients. Low ultra protective with tidal volumes less than 4 cc's of ideal body weight. Low plateau pressures less than 24. A low respiratory rate. We keep our PEEP. If they come in with a very high PEEP, then we'll decrease the PEEP over 10 to 12 hours. I learned this in my pig study on ECMO, of going down slowly to get to a moderate level of PEEP. to protect the lungs. Most of our ECMO patients are in a Craig bed, which allows them to verticalize. So that's sort of standing up in the bed. And so even when they're heavily sedated, you can still move them around. This is just an example of our Craig bed. He's at 30 degrees. It goes all the way up to 45 degrees, which is a lot of fun. You got to really strap them in because they'll slide down. Anticoagulation, as I mentioned, we do a higher heparin initial bolus. The heparin responders that don't have the thrombotic complications that are obvious, PTT goals 75 to 100. A lot of our patients have a little bit of liver dysfunction, and the antithrombin 3 is super high, so that's going to throw off your 10A levels. So it's sort of, for us, a moderate intensity heparin protocol. For the 50% that don't respond to heparin, we use Bivalirudin, and so they have thrombosis, or they, like I said, don't respond to heparin. We run a PTT of 75 to 95, which is probably more like a heparin dose of 85 to 105. Using high doses of Bival, that's not 10A down there, the Bivalirudin doses have been very high in these patients. We've also used low-dose aspirin. If on the TEG, they get daily TEGs. If the MA is fat and the patient looks thrombotic, we'll give them a baby aspirin every couple days. We had a very high rate of circuit exchange despite being therapeutic on heparin. And then we've had a high rate of CRT filter clotting. In general, of the 15 we've done, about 50% of them have significant thrombotic complications. And then about 50% of our patients are on Bival and very high doses. Sorry for pharmacy, because I guess it's expensive. We did have, I have to say, because this guy's an amazing patient, he had a full-on PE on heparin, PA arrest. You know, we weren't going to do ECPR, but we were right there, and we gave him TPA. It was amazing. We saw he had biventricular failure, classic Murray's sign, hypoxia, PEA, looked like a PE, gave him 50 of TPA, and the heart function came back. Afterwards, he had some right heart failure, and he's now on VVA at 26 days. So he's improving, actually. Hopefully in the next couple of days, we'll give him a trial off of, see if we can take him off ECMO. Our thrombotic complications, we talked about the PE in that patient. He, due to his right heart failure, before we tried VVA, we did a TPA infusion with heparin, and he actually clotted through that. I wanted to do TPA and Bival, but pharmacy said, look, we'll be able to figure out what's doing what based on the TEG if we use heparin, because you can do a heparinase study. But that didn't work, so we ended up doing a TPA infusion with Bival, hoping that if this was a pulmonary microthrombosis that was causing the right heart failure, that it would help. Helped a little bit, but not enough, so he's on the VVA ECMO. We had circuit changes that were emergent on 3 patients, despite that goal. Early thrombosis in the circuit, meaning a higher level of clot than you would normally see. In about 40% of our patients, early clotting in the cannula on 2 occasions when we were doing our cannulation, where they literally had to suck the clot out of it, even after a handsome or a normal heparin bolus. After decannulation, we've done 4 days of IV heparin and Bival. We dropped the PTT gold down to 50 to 70, use low intensity heparin protocol, or drop the Bival down. Once they leave the ICU or they're not worrying about bleeding, not having any bleeding problems, we'll give them Lovenox while they're in the hospital if the D-dimer is still elevated. And then when they're getting ready to discharge, we're transitioning to Eliquis. And thankfully, I've got an aggressive hematologist who that was willing to see them 2 weeks afterwards. He'll check a D-dimer and figure out the length of Eliquis determination. This is we know from our friends in Europe that there was a very high rate of PE and ECMO survivors. We've started CRRT initially sort of early on 11 out of 15 of our ECMO patients, and we're running 6 liters pre-filter replacement fluid at levels for cytokine removal. aware that their evidence is not there, so this is an investigational protocol. And it's also, we have to do it when machines and fluid are available. So not everyone's been able to get the full 6 liters, which gives you a filtration fraction of 35 to 40, which is quote unquote considered high flow. There's a general, it makes sense that there's a general decrease in inflammatory markers, ferritin CRP and D-dimer. And the indications are volume removal without compromising ECMO circuit flow, and then AKI. But we put a number of our patients on CRT before they've actually developed renal failure. In these cases, it was for volume removal. Proning, everybody gets prone before ECMO. Like we said, you got to earn it, even if your PDAF is low. We prone those on ECMO who don't improve after 2 days. So we're proning a lot more of our ECMO patients, and our team has gotten good at it. Improves the PDAF ratio in most patients. We had one patient who required proning after decannulation, and thankfully he's been decannulated and extubated. It was 40 days on the ventilator. He's now on the wards and happy to talk to his family. Secondary infections, we've had some, as you would expect, staph, Kleb, and Pseudomonas. Convalescent plasma has been given to 2 patients. One that had COVID brain, I'll talk about that in a little bit, and he appeared to improve. Lungs and brain got better. The other guy got plasma twice. He was a slow responder, so on VV ECMO, got plasma in the beginning of his run, and then again at 10 days. He's currently on a trial off ECMO, and we expect to decannulate him tomorrow. He will have been 19 days. Interestingly enough, he was one of our youngest and healthiest people, and he's taken the longest to recover. COVID brain, preliminary findings again. We've seen neurologic dysfunction in about 30% of patients, which is consistent with other published reports. Seizures in 3, and just before I came here, we found a 4th. So it's when we've looked for it, we've found 4 out of 5 patients have had seizures. They've improved or resolved with Vimpat and Keppra, encephalopathy has been a problem. One patient presented with hallucinations, improved with time. And then we've been using a FDA, an investigational subcutaneous EEG monitor, gives a better signal than scalp EEG, and we've implanted it in 5 COVID ECMO patients. 2 of the patients are currently sedated. We just found one, as we woke him up today, had some seizure activity. This is that it's a very, I know they talked about implanting stuff in the scalp of ECMO patients. Everyone's like, no, they're going to bleed. It's actually worked out pretty well. Surprisingly, these are very thin wires that go under it and have electrodes, and it gives you a very good signal because it's in the subgaleal space, which is not particularly vascular. And the 2 patients had bleeding that we controlled with pressure. This just shows you a printout of the clean EEG you get, and we found seizures when our scalp EEG did not. We treated the seizures and the patients got better. Now, is this COVID brain, or some of the neurocritical care guys are saying it's ECMO brain, and I'm telling them, no, ECMO is good for the brain, but we'll have to see. This just shows you, this is a quantitative EEG analysis that looks at brain activity in relation to perfusion and also sedation. Again, this is experimental, but it's been very helpful for us so far. Can let you monitor sedation levels and make your pharmacist happy by lowering their trip rates. In conclusion, ECMO may successfully support patients with severe COVID-19, lung failure, and multi-organ dysfunction. We use stricter criteria, early CRRT, increased anticoagulation, frequent proning. As I said before, 7 have come off ECMO after 7 to 19 days. The death we had was from cardiac tamponade. 5 are extubated. About 50% of that increased thrombotic complications, more so than your regular, viral pneumonia ECMO patients. They've demonstrated a stuttering course, which we've heard from our friends in Europe and Asia, where they sort of go up and down. We've seen that with our ECMO patients, and sometimes it's related to an infection, other times it's related to clotting, but thankfully a lot of our people seem to be improving. The later findings of neurologic dysfunction, a lot of those are when they wake up, and we look for it, about 30%. And then about the 7 who are still on VV ECMO, and this is including the gentleman on VVA, 4 appear to be progressing well. 3 are limping along at 1 to 4 weeks. So it's really too early to assess the survival rates. The preliminary experience does suggest favorable outcomes with VV ECMO and carefully selected patients. Like the Holt and Christian were talking about, we're coming up against we're on the border of a red zone, so we're going to get tested, and we're going to have to implement a lot of the things I learned from your excellent presentations. So thank you very much, and I'll conclude with that.
Thanks so much, Erik. That was a lot of extremely helpful information that I know the entire group that's on will, I'm sure, take lots of those points away, as well as that moment of beautiful unity when I'm hearing nurses are letting the doctors touch IV pumps. So that's wonderful. That's wonderful to hear. Unity at last. All it took was a global pandemic to let that happen. All right, so we'll transition to our last 2 speakers. I'll introduce them to you both now. Dr. Timothy Maul will start things off for you all. I'm sorry, I'm going to do some muting here. There we go. Dr. Timothy Maul has been involved in clinical perfusion technology, biomedical engineering, and cardiovascular research for the last 19 years. He's been active in clinical education, both locally and internationally through ELSO, as a co-director for ECMO simulation, and as well has been the website committee chair. So he'll start off the next presentation, and then we will conclude with Dr. Troy Seelhammer, who's an assistant professor of anesthesiology at Mayo Clinic and a consultant in the Department of Anesthesiology and Perioperative Medicine in the Division of Critical Care Medicine. He's also the adult medical ECMO medical director and has been involved in development of Mayo Clinic's curriculum for ECMO, as well as extensive care and standardization efforts related to the management of device patients. So Tim will get things started off for us, and then we will transition over to Dr. Seelhammer.
All right. Are my slides coming up okay?
Looks great.
Perfect. So I really appreciate the opportunity to provide some insight on the challenges of inflammation and coagulation from the SARS-CoV-2 patients from what I would consider the simplified perfusionist perspective. Bleeding and thrombosis have long been a source of frustration for all of us, and particularly in patients that present with the RDS from viral illnesses like H1N1 in the past and now COVID-19. Data from several adult studies have demonstrated significant tissue emboli that in all likelihood existed pre-ECMO and are also exacerbated by ECMO. In the last 2 years of ELSO data, adult respiratory ECMO patients have about a 12 to 17% rate of either oxygenator failure or circuit change. And current data right now coming out of the COVID-19 registry from the ELSO is showing about a 20% rate. So, and that 20% is consistent with some other data that I've gathered locally from some centers that are in hotspots. Some of them are ranging upwards even of 25 to 30%. And the important thing to notice too is that the odds of having any thrombotic complication on ECMO go up with each day on ECMO. So thankfully, I think most of these patients are coming off in the 180 to 210 hour time frame, which hopefully keeps you down into the 50 to 60% range. But once you cross that 10-day point, about 80% of patients on VA ECMO at least are expected to have some risk for thrombotic complication. So we could spend entire webinars, conferences dedicated to all the granular details of coagulation, inflammation, and how they're interrelated. But for the purposes of this talk, I just want to take the simplistic view and borrow some principles from Virchow's triad. In the first place, I'll start with the intrinsic hypercoagulability of the patients that present with SARS-CoV-2. So although we have a lot of unknowns about this virus, we know that it essentially causes ARDS, a hyperinflammatory response. And this touches many different areas of human physiology, including leukocyte activation, platelet activation, and all of these systems basically talk to each other. And this sets up the endothelial cells within the body to convert from their normal antithrombotic state to a prothrombotic, making clots form, and the vessels were where they should not be forming at all. This sets off a continual process of thrombosis, microvascular occlusion, and reperfusion injury as these clots break down that perpetuates the cytokine response and eventually leads to end organ injury. In a small study comparing some ECMO patients to patients and coming in for routine cardiopulmonary bypass, we had seen that pre-ECMO, their D-dimer and F1.2 concentration, so indicators of ongoing clot formation, were significantly higher than patients that were just coming in for bypass for heart failure. And so we know that these patients are primed to begin clotting. And the interaction with ARDS and platelets has also set up some interesting studies where people are using aspirin as one of the frontline anticoagulants to help limit the platelet activation in these patients. And there have been a few studies that have shown that aspirin will decrease platelet absorption to your oxygenated fibers, and paradoxically will also decrease the need for transfusion. So even though you're giving a platelet inhibitor, these patients tend to actually bleed less than their counterparts. The next leg of the triangle is the artificial materials that make up the ECMO circuit itself. So we know that as soon as blood contacts any foreign surface, it begins protein deposition. And this protein deposition actually changes over time as a function of time, bulk flow, concentration of one protein or another, and the relative affinity of that protein for the surface. So an ECMO circuit that you see in day 1 is not the same as our ECMO circuit on day 2, day 5, or even day 15. We know that fibrinogen is a major contributor to this contact deposition, and that materials that are hydrophilic, meaning that they like water a little bit more than just base plastic, will absorb fibrinogen less than the ones that are hydrophobic or completely uncoated. And what happens when these proteins come down to the surface is that they actually change their shape, and they hide their hydrophobic surfaces away from the water and put them in more proximity to the plastic surface itself. And so what this does is it changes the conformation to allow activation from other elements like platelets, coagulation cascade, and complement system to then start off this process of consumptive coagulopathy that we know happens in ECMO. And we can see this activation of the coagulation system occurring rather rapidly. Within 2 hours of going on ECMO, you can see that there's huge spikes in most of our molecular signals of the coagulation system. And so one of the tools that we have to help combat this has been the availability of our coated circuits. Circuits containing heparin like Carmida, Corteva, Bioline, the phosphorylcholine coated surfaces, or amphiphilic polymers like you'd find on the Softline brand. They all do similar things where they reduce platelet activation and attachment. The putative mechanism for this is reduction in fibrinogen and other protein bindings that makes these surfaces less hydrophobic. And then you can compare that to the old Safeline coating, which was basically covalently linked albumin to the surface, which actually had really almost no effect on platelet attachment. So, and this is also similar to surfaces that don't have any coating at all, which is what most of these other studies are comparing to. We also see evidence that protein interaction by phosphorylcholine and heparin surfaces reduce complement activation, which produces the anaphylatoxins that cause the third spacing. They can lower cardiac contractility and a lot of the other bad ECMO side effects. And then, of course, the complement system also crosses over to the coagulation system. So anything that we can do to blunt platelet activation, fibrinogen deposition, and complement activation would at least give us some leg up in the early stages of ECMO, particularly with these patients that are coming in this hyperinflamed state. And although the coatings do help with this, we do have evidence that it doesn't last very long. So some of the early studies with Carmida showed that within about 6 hours, the effect of the coating was no different than an uncoated system. So these surfaces give us a small window to get our anticoagulation appropriately established and up to the point where we would want it. And the other important thing is that none of the coatings have been shown to directly affect mortality, length of stay, chest drainage, anything. So everything is short time frames as far as testing from the manufacturers, and so you always have to take that with a little bit of a grain of salt when you're evaluating all of the different coatings that are available. This table highlights some of the various coatings available on ECMO oxygenators in the United States, along with some of their basic performance characteristics. Many of us have faced shortages of our preferred oxygenator and been utilizing some newer entries into the market, but even some of those are forced into allocation now. I highlight the MEDO system in red because I was just informed that that is probably coming off the US market as a result of the German company's push to bring the Novolung back to the United States. But it was in the United States with no coating, and it's not a system that I would recommend unless we were out of options. When I'm looking at the systems that are available, I think that the systems with phosphorylcholine and the soft-line polymer probably are frontline best choices for coated systems because it will reduce this protein deposition. I'm a little hesitant to recommend BioLine because it has an albumin component to it. And anecdotally, I've seen some patients that did respond well in air to this coating. I switched it to phosphorylcholine, and a lot of the white fibrin deposition that I was seeing in my ECMO circuits seems to get better. And then the last leg of the triad, of course, is blood flow. And what can we do to, looking at our ECMO circuits, reduce the chances for creating thrombus within them? So every time that we introduce a connector, a diameter change, a change in the shape of blood flowing into an ECMO circuit, we're basically squeezing the streamlines of the blood into that shape and then letting them expand back on the other side. And what that does, it creates these zones of recirculation where the blood doesn't move forward any longer. And this sets up all of those areas of ring thrombi or clotting in the corners, especially for the quadrox oxygenators that we have come to know and sort of beat our heads against the wall for. So in patients that are hypercoagulable, it's important to reduce all of our connections as much as we can and keep these zones of stagnation moving by purging lines, hep blocking, or even giving small infusions of saline with or without heparin, like we would do in any normal central vascular line for a patient that's in the ICU. And then the last thing I want to leave you with is what I believe to be fundamentally true about ECMO, and that's we're dealing with a highly complex biological system with lots of redundant pathways and crosstalk. And no single solution is going to solve any of the challenges that we face. We're doing what we can to intervene the various parts of the process based on extrapolation from other patient populations, basic chemistry and biology, but ultimately we need comprehensive research studies that are based on good interdisciplinary science backed by solid data instead of anecdotal evidence. And I wanted just to show that, even back as far as 1997, we know that, we give steroids to patients before ECMO and on ECMO. There's recent publications that are talking about tocilizumab and vitamin C in some of these COVID-19 patients. I would love to see aprocitentan come back to the United States. I think this would be a nice addition to our armamentarium because it's a serine protease inhibitor, and that is central to most of the inflammatory and coagulation enzymes that we find within our systems. A lot of the centers are using ultrafiltration or CRRT, which can help with reducing the cytokine loads, and there's even some new products hopefully coming out in the next months to year that will give us some leukocyte depletion abilities to basically get rid of the activated leukocytes or selectively remove certain cytokines from our ECMO circuits. So with that, I'll turn it over to Dr. Seelhammer and to talk about what they're doing from their anticoagulation standpoint in their patients.
All right. I'd like to thank ELSO for organizing this webinar and for the opportunity to speak today, and also for Dr. Maul for helping to set the stage for this portion of the presentation. No conflicts of interest to disclose today, although I should mention that Bivalirudin is FDA approved for use during heparin-induced thrombocytopenia concerns and for percutaneous coronary intervention, so its use during extracorporeal support is, of course, off-label. This has been discussed by nearly every speaker today, and the audience is likely well aware of this already, but there are differences between the COVID-19 population and prior cohorts. And looking back at just some of the published data, and there's a Dutch experience looking at 3 hospitals, and they found almost a third of their population had thrombotic complications as confirmed by ultrasonic studies. And this is despite prophylaxis administered to every patient. The Tang et al. Was one of the earliest publications in the Wuhan, China experience, and what they found is that those that did not survive, they had elevations in all of these markers, D-dimers, fibrin degradation products, elevations in prothrombin time, and activated partial thromboplastin times. And this is perpetuated throughout their intensive care course. And this is out of about 183 patients. But overall, if you had to sort of summarize what we're dealing with here, it is unfortunately a paucity of good evidence. And Dr. Maul just did a nice job of belaboring that point as well. So the crux of the controversy here, and really this is sort of a dipole here. There's 2 sides of this equation. One is that COVID-19 is probably prothrombotic, and that has to deal with likely the microvasculature. Perhaps it's the endothelium. There's certainly a degree of cytokine storm that is created, and this may exacerbate pre-existing hypoxemia, or certainly it can precipitate it on its own as well. And this can cause clinical deteriorations needing aggressive support, including mechanical ventilation, proning, and of course ECMO. On the other hand, this hasn't actually been confirmed by very good data. We know in every webinar and many popular press articles, and certainly every gathering of individuals, we talk about these issues, but we don't really have good data yet. And we do know that that all hospitalized patients have elevation risk for VTEs, and that those with ARDS and those with sepsis have another escalation of risk. And so these patients should be, as a minimum, prophylaxed for VTE. And if you're going to pharmacologically treat them, particularly the more sick that you get, you want to use adequate dosing strategies. That doesn't really answer any questions. And myself, like I'm sure many in the audience today, are left scratching our heads on what to do next. And we find ourselves standing at the, currently outside the rooms, wondering how we gather this disparate amount of information coming from our lab tests and coalesce them into a titration plan for pharmacologic therapy on ECMO. And this is not a trivial task. And what I'd like to do is to try to simplify why we use anticoagulation on ECMO, and sort of a working person's interpretation of why we do this, and then try and offer some strategies that might simplify things going forward. So I'd like to just touch on the coagulation cascade, not to put everybody asleep, but rather because if we're going to decide where and how to intervene pharmacologically for clot formation, we have to understand, at least in its simplified form, how this pathway unfolds. And if you think about the intrinsic side of this cascade, there's an entry point with collagen, and you get activations of a series of proteins, including factors 11 and 12. And these coalesce, and they end up activating 3 more proteins, factors 8, 9, and 10. This conglomeration of zymogen precursors, once activated, forms the 10-ACE complex. The 10-ACE complex activates factor 10 to its active form, thereby serving as the entry point to the common pathway. And just keep this in mind, it's central in this slide for a reason. But there's another entry point, and that's the extrinsic side of this cascade. And here, other proteins, primarily in the endothelial walls, including tissue factor, directly activate factor 7 to its active form, and thereby directly, bypassing all of the intrinsic side, activates factor 10. And here, now the cat's out of the bag. And once you have factor 10, you cleave prothrombin to its active form. And thrombin itself is a serine protease, and it serves very quickly to cleave soluble, that is freely circulating non-polymerized fibrinogen, into insoluble fibrin. And then when it falls out of this freely circulating form, it starts to polymerize. And when it does so, it polymerizes primarily locally and eventually more systemically as well. And you get this interlacing mesh network of fibrin that gets cross-linked around activated platelets and red blood cells, forming a platelet plug. And in our world, with extracorporeal support, we can deal with complications like this just being an example of embolic or thromboembolic phenomenon occurring on the oxygen interface plate. So let's look at thrombin itself, and this will have a lot of relevancy later on in the presentation. On the x-axis is time in minutes, and this all happens very, very quickly. So on the left side, 0 minutes, on the right side, 16 minutes. Notice the y-axis, this is serum concentrations of thrombin. When you activate the cascade with tissue factor, within 10 minutes, you get an 8,000-fold increase in serum concentrations of thrombin through a very potent, powerful amplification and feed-forward pathway. So if you had to boil down into its simplest form, I would argue that the purpose of anticoagulation with extracorporeal support is to mitigate the classic contact phase activation that occurs with the foreign material and extracorporeal circuit when contacting circulating blood, because that creates thrombin. So the purpose then is to quiet down the action of thrombin, either negate its production, or if produced, to quiet down its ability to perform its next task. Let's take a pause here and conceptualize the ideal anticoagulant. Well, you want to effectively quiet down the secondary hemostatic cascade that involves 30 proteins. You want it to be free and devoid of negative side effects, including heparin-induced thrombocytopenia, allergy, anaphylaxis, and interdrug reactions. You want it to be readily titratable. This is critical. You need a reliable dose-response curve, ideally linear. You want to have a lab assay that you can send a lab off and know exactly how much systemic anticoagulant effect you're achieving. And then lastly, ideally you'd want this drug to have an antidote. And if you don't have an antidote, a clinical half-life that's short enough whereby it's clinically not relevant, you could just turn the drug off. If you can achieve a delicate balance of all three of these, this would be an ideal drug. But unfortunately, we don't have this. In fact, we're actually quite a ways away from this currently, but get better, I think. So by far, the most centers around the world are using heparin. It's widely available. It's inexpensive. We know and love it well, but it doesn't act directly. It relies on a second protein that we have to worry about, antithrombin 3. So once heparin binds to circulating antithrombin 3, it increases its action by 4,000-fold, thereby blocking the ability of factor 10A and activated thrombin to do their job. That's how the drug works. That means we have to worry about serum levels of both heparin and antithrombin 3. So it has limitations. We don't have time to talk about all of them, but one of them is a long half-life that's highly variable. It's cleared in really unclear mechanisms, macrophages, endothelium, but it varies between individuals. There's also potency variation because it's a bioextract, so there can be some issues there as well. An unpredictable dose-response curve, it's certainly not linear. You need frequent lab tests. It seems like those of us that do this for a living, every time we send an APTT or an ACT, guess what? We get to change our heparin dose as well. And then heparin resistance, and this is because of that second protein effect. And so you have to, if you're dealing with resistance, either empirically replace with FFP or concentrate, or at least draw an assay level and then consider replacement. Because in some individuals, irregardless of the heparin dose administered, you're not going to achieve your desired results. And then lastly, the feared complication of heparin-induced thrombocytopenia. With the COVID-19 population, thrombosis is being seen, as you've heard about earlier today from Dr. Osborn and Dr. Maul, with APTTs in the normal high therapeutic range for ECMO. They're still thrombosing. So what else can we do? This is the segue into direct thrombin inhibitors. This drug class is, and indeed is an entire class of medications. We'll talk and focus mostly about Bivalirudin, but there is others, including argatroban. Bivalirudin, at least in our experience, is preferred because its half-life is shorter than argatroban, and it doesn't rely on the liver for its metabolism. The drug acts, it's a synthetic drug, and so the potency is reliable and consistent, and it directly binds to thrombin and negates its ability to cleave that soluble fibrinogen into its insoluble fibrin form. This seems like a nuanced point, that it can bind to and act on both free and clot-bound thrombin, but it's not really as unimportant as it might seem. And this is just a rendering that shows a red blood cell with these activated platelets, very similar to the slide I showed you earlier. You can see this mesh network of fibrin, and there's thrombin pointed out here. The drug can bind to and inhibit the action of thrombin at these local sites of start to degrade this clot over time. And you can actually see dissolution of formed fibrin laydown or dense clot on circuits over time in the setting of therapeutic direct thrombin inhibitors. So this is really, really important. And if there's a superiority aspect of Bivalirudin, I would argue it's probably this. It's immediate onset, so you don't have to worry about a delay. Sure, you can bolus it, but its half-life is short enough whereby you get systemic anticoagulation within an hour or two in many circumstances. Its clearance is non-organ specific by blood proteases. That last 20% that's not by blood proteases is renally cleared, so some dose adjustments for kidney function are essential. So this same slide you've seen 3 times now, looking at Bivalirudin, it directly inhibits the action of thrombin. If you can't make thrombin, or you can't have thrombin functioning, you can't cleave fibrinogen into insoluble fibrin. Its clinical advantages are what I've already described to you, and then a more predictable anticoagulant response because it doesn't rely on a second protein. It doesn't have any action on platelet factor 4, so it's not just safe in HIT, it's actually indicated in HIT. So if you have any concerns at all, this is an excellent drug choice in this setting. Thus far, what's published for ECMO and Bivalirudin remains fairly modest, and let's just swing through a few of those articles that have come out in the last decade. And dating back to 2009, started with some case reports. This is derived dosing strategies from cardiopulmonary bypass using ACT to titrate anticoagulation. In 2011, I would argue one of the most impactful articles was published by Dr. Renuzzi et al., looking at 21 post-cardiotomy patients, and they found some interesting findings. A reduction in APTD variation, a reduction in cost of administration, despite the drug costing 20 times more than heparin. And this is likely driven by reduced lab frequency along with less blood loss, and because of these features, less transfusion. 2013, there was a case control study, and they showed a reduction in supratherapeutic APTT. 2017, a systematic review. Notice this now, in 2017, total, just 8 publications, 5 of which were case reports. So our evidence is just not as robust as we'd like it to be. But what they did report is some typical dose ranges, 0.1 to 0.5 milligrams per kilo per hour, and that you can assay a variety of lab tests to titrate, including APTT and ACT. In fact, thromboelastography was used in one study, although this is controversial. In 2018, there was a retrospective study using a nicely described dosing protocol. And the same year, there was an article showing no difference in outcomes. 2019 showed that you have to use higher dosing rates if you're using renal replacement therapy. This is expected based upon the pharmacology of the drug. In 2020, just recently, an article looking at pediatric cardiac surgery and postulated you could circumvent many of the traditional problems with heparin by choosing this particular agent, which still leaves question mark. Should we use this in COVID-19? Well, let's take a pause and talk about what we know so far, at least in our center. We use it as a first-line agent for systemic anticoagulation in nearly all patients. It's indicated in heparin-induced thrombocytopenia, and if you're struggling to get therapeutic for the reasons we've already discussed. Lastly, if there's refractory deposition, you have the antiplatelet therapies, you've got therapeutic APTT and heparin, you can consider switching to Bivalirudin because it acts further downstream and directly, and we deem it to be a superior overall anticoagulant for these reasons. We developed a first-generation guideline in 2016, and this was based upon the limited published data, particularly in heparin-induced thrombocytopenia, but it did not have any renal dose adjustment titration schedules embedded within it. In 2018, we used our initial experience on 26 adults to then derive a robust renal dose titration table, and also added some other nuanced stuff like how to handle Bivalirudin if you're going to use low ECMO flow, less than 1 liter a minute. We had to spell that out so that we could standardize our practice. In 2020, we rolled out just recently our 3rd generation guideline, now using 122 of our own Mayo Clinic Bivalirudin adult ECMO patients, and we extrapolated what was required to get them therapeutic so that we could theoretically in the future get them therapeutic even more quickly with less titrations. We also added some uncommon scenarios like antiphospholipid syndrome, if we're going to plasma pheresis patients, and heparin-induced thrombocytopenia management, and how to handle dialysis start, stop, and pause situations. In total, thus far, we've employed Bivalirudin on 208 adults and 87 pediatric patients. We rely on an algorithm to dose this, both on when to start and which lab tests to use when titrating this drug. These slides, these images are small. They're not intended to be to help guide your therapy. It's just as a suggestion, try to develop an algorithm, rely on something firm to manage these patients on Bivalirudin. We also use a later stage second portion of our algorithm to decide what to do when things aren't going as planned. And what we end up doing is starting our dose based upon estimated GFR, creatinine clearance. And as you can see on this particular table, taken directly from our guideline, if you look on the left side of the creatinine clearance, on the right side is our Bivalirudin dose. And for example, if you're on dialysis, we start at a more modest amount of systemic agent. And then we apply it when we check our next APTT to a titration schedule, and we decide, are we therapeutic or not? And we decide a dose adjustment based upon this set criteria. Our experience has been, interestingly here, if you were to ad hoc deploy Bivalirudin, use non-ECMO patient-derived titration schedules, pharmacy dosing, whatever we think the right dose should be, we're not as good as we think we ought to be. And if we employ a guideline instead, we markedly truncate the time it takes to get therapeutic and also the number of steps it takes us to get there. So this is a nice re-encouragement of the importance of a guideline to guide therapy. Our outcomes pre-COVID showed a reduction in mortality and complications, and we're actively doing our final analysis currently, so hopefully more to come on this in the near future. We just currently have one patient with COVID positive on ECMO, and I wanted to show you just one demonstrative slide because I think it speaks volumes to how this drug acts differently than heparin. This particular individual on the x-axis is time. This is a 7-day window. Notice that we start the drug infusion at 0.25 milligrams per kilo per hour, very quickly get therapeutic, and then we maintain therapeutic range, APTT ranging between 60 and 80 for 7 days without a single dose adjustment. And this is continued to be the case currently. I just didn't update the slide, but we still have a fixed dose bivalirudin unchanged with no thrombotic complications. Also note that we used aspirin on post-ECMO initiation day 0. Implementation considerations. It's essential that you know when not to use bivalirudin. And more specifically, one of the only times we don't use bivalirudin is if the heart isn't ejecting. What's known is that because the drug is cleared non-organ dependent fashion, it is proteolyzed and the drug effect is lost locally. If you don't re-administer or re-deliver new drug compound to that local site, its local anticoagulant effect is lost, and you can end up with thrombosis. This can occur in a cardiotomy chamber. It can also occur in myocardium, particularly if there's foreign graft material like an artificial, particularly mechanical valve. You want a titration schedule that's well established, ideally derived from ECMO patients because the pharmacokinetics do differ. You want a plan for how you're going to handle dialysis, and then there are some nuances, one of which is a nonlinear dose response curve, really just at the high levels of anticoagulant dosing. It's something termed bivalirudin resistance. You can read about it on a variety of publications. Really, we don't know what's driving it, but if you're getting doses higher than 0.5, you may want to consider other assessments, including a direct factor 2A functional level or an eccrine clotting time to assess a dose response because your APTT might not be reliable at doses that high. There's a lab reagent interference with INR causing an artificial elevation in INR. So if you're on bivalirudin, expect to see a 0.3 to 0.5 elevation in INR. When you go to transition from bivalirudin to warfarin, you can consider using a chromogenic factor assessment to help guide that transition. Hemorrhage management, you can dialyze these patients theoretically, but implementing dialysis urgently and acutely in hemorrhage is not really feasible. Fortunately, its kinetics are short enough where we just terminate the drug effect, and then we manage these patients as other ECMO hemorrhage situations. Lastly, last comment here, low flow states. You need to consider alternative anticoagulant when you have ECMO flows less than 1 liter a minute that's sustained, and certainly any time less than 0.5 liters per minute. That's because relative stasis predisposes the patients to clot formations for the reasons we've previously discussed. Take-home points, just ECMO is unique in the setting of COVID-19 with an increased risk of thromboembolic complications. Controlling thrombin is key, and this doesn't matter if you use heparin or thrombin, you have to control thrombin action. Heparin is the most common, but it isn't the only option, and at the Mayo Clinic, we find bivalirudin to be superior in our practice.
Wonderful. Thank you so much. A lot of content, and I think as Tim said, you could literally fill a whole day's worth of content on anticoagulation. So I gave you guys quite the challenge to tackle that in 10 and 15 minutes. So thank you everyone for joining. This was so much information, and based on the flood of texts and emails and chats that I've been receiving privately, I greatly appreciate the information you guys were sharing. I think the audience found it very helpful. For the audience that is with us, I know there's a few lingering questions that I am going to pull off from our Q&A session, and I will get them out to the speakers and see if they will so graciously give some responses to those that are still open-ended. And we will post them along with where you'll find the slides as well as the video recordings. Video recordings give us about 24 hours to get those pulled down and put up onto our YouTube site. The slides should be available almost immediately after the webinar. So thanks everyone again for joining. Thank you to our speakers. Wonderful job, great information. Thank you to Tammy Frederick and Velia, who are behind the scenes feverishly helping me answer questions. I appreciate them immensely trying to navigate all the technical elements of everything, and hope everyone continues to stay healthy and stay safe. Please watch our webinar, or watch our website as well as our social media sites. There's a lot more ideas brewing for future webinars, and I do anticipate a couple more webinars popping up in the next couple weeks. So stay tuned, you'll hear from us again. Thanks everyone.